Hello and welcome to Slide Review. So today we are looking at the challenge cases associated with our DermPath 4 lecture, which was looking at melanocytic lesions. So as always, we have our disclaimer. And as always, if you have any questions, comments, concerns, conundrums, things you'd like to see, not see, please let us know. And as per usual, because we've already gone over this lecture, which I'll put the link in the description of the video. We're not going to go over all this stuff since we've already seen this. And we're just going to concentrate on our 17 challenge cases. Okay, so a lot of these lesions are difficult. Some of them are just more examples of what we've seen before. So let's get started. Case 1. So immediately what catches our eye is all this stuff on top. Okay, so this is obviously going to be a big component of this lesion. And some of you might even be able to pick out some of these keratin pearls. Okay, so this already looks like a seborrheic keratosis, which is part of the aspect of this lesion. Okay, so for anyone going, hey, this is a seborrheic keratosis, you are halfway there. Okay, so remember, seborrheic keratoses, we're not really seeing atypia in this, but we have this profound hyperkeratosis. You do have these peaks. So remember, sometimes this can look similar to like our verruca or our warty keratosis when you're not quite sure, is it a verruca or is it a seborrheic keratosis? But we start seeing stuff like this, and there might be a little more here. Okay, so remember we have these adnexal structures and we're seeing stuff underneath them. And because this is melanocytic lesions, a little more of it here, this is where we should really be honing our eye in. So it's not incorrect if you were looking, you're like, hey, this is an SK, I'm done, except that you're not done, and this is why. So if we go underneath these adnexal structures, what we see are all these somewhat epithelioid, somewhat spindled cells. Some of them have nucleoli, but they're relatively bland looking, a little bit of clefting, and these are melanocytes, okay? And melanocytes going underneath our adnexal structures. This is a feature of congenital nevi. So what this lesion actually is a seborrheic keratosis, okay, so seborrheic keratosis arising within a congenital nevus. Okay, so the nevus was already there and they developed an SK over top of it. So I just thought this was really interesting and just a good reminder that even though I know for myself going through the challenge cases and even during the lectures, we tend to hyper-focus on one or two things, but multiple things can happen in real life, so this was just a nice reminder of that. Moving on to case 2, we have this little detached fragment here that is inked, so this would probably be your deep resection margin. Looks like they have black on the lateral aspects, and what we see is that it's very, very blue. Lots of blue here. But all this is too blue, right? This is skin, so we should be seeing some pink. And at first glance, I admit myself that like this is what drew my eye. So we are going to look at this, but this case, really I wanted you to focus on everything that was going on here. This stuff's just detached and normal. It's fiber adipose tissue, but if we go in, what we see is that this isn't the collagen fibers that we would expect in our reticular dermis. Okay, we're again seeing these somewhat spindled, somewhat epithelioid cells. Some of them have nucleoli, like this guy. Okay, but they're still pretty bland. There's nobody here that's really scary. And what we notice if we go from the surface, which is over this way, is that here they start off maybe a little bigger, it's a little more blue, and they get a little smaller, a little more pink as we go down. So remember, we would say that this is maturing, so that's a good sign. Okay, so see how small these are, and they have ample pink cytoplasm. Maybe some of it is amphiphilic, but for the most part, this looks pretty pink to me. And we're seeing that it's underneath all these structures. Like this goes really, really deep. Okay? Again, you can start picking it out, and hopefully, if you've been with us a few weeks, you're starting to pick up some of these things at lower power, because remember, low power just gives you a general idea of how far everything is going, the general architecture of everything. And then when we get to here, we can see that this is normal collagen fibers. So, okay, so we know that there's a component of congenital nevi, right? This is a congenital nevus. It's maturing, it's happy, it's underneath all these structures. Okay, so what's all this dark blue stuff, right? Because this was the stuff that really caught our eye. And if somebody is maybe thinking, hey, I was wondering about basal cell carcinoma, that's not a bad idea at all, because of how blue it is. But once we get to high power, we can see that, again, these cells are very similar to what we were seeing in the congenital aspect, but there is more variation in size. Okay, there's more prominent nucleoli. Unfortunately, this is as high as you can zoom in on everything. It's more cellular, right? Everything's more crowded. We start to see mitotic figures. I promise you, there are mitotic figures, and some of them are a little on the bizarre side. And again, this blueness, right? So remember, one of our features of maturity is that this should be less blue as it gets deeper. It should mature. It should become more pink, and we still see that same blue, even at the bottom of this lesion. Okay? So here where our normal melanocytes are like over here, and we see that, yeah, there is some variation in size, but for the most part, they're very small. Okay? Maybe go to an area where they aren't more lobular in appearance, just to make it a little easier to see, like over here. So I feel like this is a good contrast where we have these very immature appearing, irregular melanocytes, and then over here we have the maturing variant. So you can see the difference here. That's probably a better area to show you. And then again, we see how this is coming underneath the adnexal structure. But okay, so we have atypical melanocytes. Oh, waiting for our slide to load. They are not showing maturation, right? And whether this is a punch biopsy or this is some kind of cut. So whether this is from a punch biopsy or this was a section and this is where they cut this aspect of the lesion, all this over here, this is nodular melanoma arising in a congenital nevus. So remember, multiple things can happen together. And just because your eye is drawn to something doesn't mean that you shouldn't look at everything else. So that's really, with these first two cases, what I want to show you. Case 3. So this one I thought was a little trickier. Okay. And not tricky in that, okay, we have melanocytes here, a relatively happy epidermis, and maybe like some vessels. But what I thought was tricky about this case, so this was why I chose this one, was that we didn't have any extremely prominent adnexal structures. Like maybe here's part of a hair follicle, but it's difficult to tell. And kind of the same thing over in this piece where we can see that we have this very extensive dermal component of this nevus. but no extremely prominent adnexal structures. So this is still a congenital nevus, but besides the vessels and the depth, I thought this one was pretty difficult. Maybe that one hair follicle. So with, and you can see there's a little bit of solar elastosis going on there. So would it be wrong in this instance to say, well, this looks like maybe this is a dermal nevus, an acquired dermal nevus, and leave it at that? I don't think that's necessarily the end of the world. This doesn't look irritated or malignant, but just something to keep in mind. And maybe find out in the patient's history that, you know, maybe this is a pediatric derm case. Like maybe they're 5 years old. Well, that would be unusual for them to already have acquired nevi. And, you know, or they could just even tell you like, oh, this is, the patient refers to this lesion as their birthmark, but they would like it removed. So again, another variation of the congenital nevus. Case 4, so we have 2 pieces, 2 cuts, so you can choose whichever one you like. And we can see that there is, again, this dermal component. There are some maybe epidermal nests, maybe subepidermal nests, and we can see right away the blue that's going underneath the adnexal structure, underneath the hair follicle. So, and again, seeing these very nice bland melanocytes. You can see those nucleoli, but they're not macronucleoli. There's a general monotonous feel to this lesion. Okay, like yes, some of the cells are a little bigger, but there's nothing really bizarre looking about this. And even if we look at the nests, yeah, this one, like these might be epidermal. This one's epidermal. You can still see that these are relatively happy looking nests. Okay, they're not super regular. This is another variant, well, another example of a congenital nevus. Just a little more of the same on the other piece. Okay, and again, a little hard to appreciate on this because it is more sparsely cellular, but there is, again, this semblance of maturation and not too much going on in the epidermis. Case 5. Okay, so it looks like we're on to something a little different, right? We can see that this is our lesional area. This doesn't really look like anything, so we're going to concentrate over here. We can already see the pigment. And what we can appreciate, hopefully, is that it's all within the melanophages, right? So these macrophages that gobble up all the excess pigment. So they are really what catches your eye as far as pigmentation goes. And then we have these somewhat elongated or spindled cells that look a little different, maybe from the melanocytes we've seen in other lesions, but they're still relatively bland. A little more variation in shapes. Trying to see if we can see any that, maybe this one, the elongated dendritic processes. You have vascular spaces. So what this is this is a blue nevus, but there's so many cells going on here. So this is actually a cellular variant of the blue nevus, which is not one that I believe I listed within your variants in the lecture. So again, could you leave this as just calling this a blue nevus? Well, possibly, but whenever something's cellular, we kind of want to keep an extra eye on it. There's nothing in this that looks, at least to me, that looks really atypical and scary looking. But remember, the pigmentation is typically within those melanophages. So this is another example of your blue nevus. Case 6, again, 2 levels of the same cut. And that beeping tells me someone has a pager that wants a new battery. Okay, oops. We'll just add a full screen there. Oh, here we go. So we start seeing some nesting. See if we can find maybe a better area though. This area, so hopefully you can appreciate that even though it's subtle, here's some more, it's slightly more gray than the purpley blue that we're seeing in the rest of the epithelium. Just a little more here. And again, seeing those melanocytes. Let's see what the other pieces have to hold. Those look like macrophages. Here's some more of it. So again, we have, at least so far, these epidermal nests of bland-looking melanocytes that are essentially confined to the basal layers, so that makes us all happy. Here's some more of the macrophages. I think this is more of it. Wish it was maybe a little more nested to help you out, but this is why these are challenges. Okay, so that first piece might have been best. We'll go here because this to me actually looks like a nest. So we have these basally situated nests of melanocytes. Again, a little more over here and here. But I think these are maybe somewhat difficult to pick up, and obviously the higher in power you go, the more you lose that sense of nodularity. And everything is confined to the epidermis. And even though this looks like maybe it's a little papillary, I'm not seeing anything that really strikes me as atypia. So for this, I would probably just leave this as an acquired nevus junctional type, or just a junctional nevi. This has likely been here for quite a while. Looks like, again, maybe a small nest here. Okay, but everything's in the epidermis, so just a junctional nevus. If someone wants to add anything to this, we'd be happy to learn more about this, or just to see everyone's thoughts. Case 7. So even at low power, we can see that our epidermis looks relatively regular. Maybe some areas that are more pronounced. And it seems like there's something going on in the dermis. And that's exactly what we have. So what we have is a smattering of, again, these relatively regular epithelioid to spindled cells. Again, you can see those nucleoli, and this is the highest power you can go on this case. We're not really seeing it go underneath any adnexal structures, so what I'm saying is I don't think we're seeing features of congeniality, or congenital features. That's easier to say, congenital features, no congenital features. But just this loose speckle of melanocytes. It's kind of hard to tell. I'm partly because this case is so pink, if they're really maturing, but they don't look scary. And I'm not seeing any nests at all. Well, no, that doesn't look like melanocytes. Okay, so far no nests within the epidermis. So we'll check the epidermis quick here again. Now remember, you are allowed to have scattered melanocytes within the basal layers of the epidermis. That's normal. So without a true nest of them, you wouldn't want to say that you have an epidermal component. But at least in this, I'm not, like, maybe this is suggestive that maybe it would come underneath here, but we can't see that. So we're just going to comment on what we can see, and all these melanocytes within the dermis without any epidermal component. So this is, at this point, an acquired nevus dermal type, or dermal nevus. Excuse me. And I would probably just mention in a note that it's present at the deeper section margin. This isn't necessarily something that they would go back and excise, but they may if the patient, like if this was maybe a prominent nevi, like on their face or something like that, or, you know, sometimes patients just, they hear that they have something and they want it gone, and there's nothing wrong with removing it at that point. But this does not look atypical or irritated, so not necessarily something that they would have to go back and take more. Case 8. So we definitely can appreciate on this that there's something going on in the dermis, but even at low power, I can see that there's something also within the epidermis. So you probably already know where I'm going with this, so we're just going to take a look over here since I can see both components. And sure enough, we have some small epidermal nests of melanocytes. Okay, we can just kind of see those percolating through the basal layers of the epidermis. I don't know what I think about that. That seems like it's a bit high. Maybe I'm overthinking that, but okay, maybe it's just tangential and up here isn't actually. Okay, that makes me feel, whoops, a little better. But okay, so we have both an epidermal and dermal component of these melanocytes. Just trying to see if we see anything else. There is some maybe increased collagen deposition within the papillary dermis. So maybe this has been irritated at one point or another, which is totally possible. We have a little bit of a dermal lymphocytic component. Remember, our focus is these melanocytes. So what we have here with both our dermal and epidermal components is this is a compound nevus, an acquired nevus compound type, because it has both epidermal and dermal components. Sorry, to make that more clear, since I realized I was in an area where it was more single cells, we have nests that are within both the epidermis and dermal components as well. This is case 9, and there's not a lot here, but hopefully you can see this pigment already. This is very characteristic of this lesion. So we have this ochre yellow, somewhat banana-shaped deposits of pigment that otherwise doesn't have too many characteristics to it. So this is very characteristic. This is ochronosis. Just to give you more examples. Case 10, so again, we see the pigmentation, and hopefully even at this power, you're thinking, this looks like ochronosis, and guess what? It is ochronosis. I just thought this was really lovely because the shapes really weren't necessarily banana shaped in this one, and you can see more of the glassy appearance of the pigmentation. So I just thought this was a really nice case for that. And what you're seeing in some of the pigments is that this looks like red cells trapped within the pigment. Okay, so ochronosis. Case 11. So what we see is that there's definitely something going on in like the papillary dermis, right, the superficial dermis. And we can see that there's this subepithelial clefting, like even at this power. Okay, so is this, actually this one might be within the epidermis. Let's see, we can find a few other features. Yep. And these pink inclusions, these are camino bodies. This looks probably dyskeratotic because it's super, super pink. But yeah, these look like relatively spindled cells. We have the artifactual clefting, sorry. Don't think I'm seeing anything. It looks like giant cells, which you can see. Doesn't look like we have pseudoepitheliomatous hyperplasia, which you can also sometimes see with this. Is that another camino body? That looks dyskeratotic. Maybe that's a camino body. It looks better for one. But we have camino bodies. We have all this other stuff going on. So this is a Spitz nevus. Okay. All right. So I'm happy with that. Spitz nevus for case 11. Case 12. And this looks like maybe it's either super darkly stained, which happens sometimes, or it's really intense pigmentation, because this looks like that was stained okay. So let's just take a look at this piece, which maybe doesn't help us all that much. There's a lot of pigmentation for sure. But we can't say too much about these cells. Let's try this piece. This, I'm getting a better sense of what's going on, so I can orient myself. These are the basal keratinocytes, and we have these pigmented cells that are traveling up towards the surface of the epidermis, but our surface is gone. And it looks like we have some melanophages within the papillary dermis. Okay. I think this is the piece to look at, this big middle piece. So if you're spending some time on the case. And I say that because here is your surface. So here's our keratin, which we can still see pigmentation within the keratin and some of these cells. And what we have here is these are melanocytes. Okay, some of them are pigmented heavily, some aren't. But you shouldn't see melanocytes so far up in the epidermis, right? They should all be within the basal layers of the epidermis, and here we're seeing them come all the way through. We have these pigmentation granules that are going straight through our superficial keratin or orthokeratin layers. So this is at least, since again it's extremely superficial, This is at least melanoma in situ. It is present at the lateral and deep resection margins, or at least lateral, because it's hard to tell like if this was all one piece at one point or if it's separated. And like I can't evaluate what's under here, so I'm not actually sure if there's maybe an invasive component, which could very well be there. So I would just leave this as melanoma in situ. It doesn't really look like any of the patterns, so you'd probably just call this an NOS or not otherwise specified. But even just leaving it as your top line, melanoma in situ, C note, and then at note explaining what you have here for the margins, I think would be sufficient. Stains, remember melanoma likes things like SOX10, S100, HMB45, or MART1, Melanase, so all those kinds of things. Okay, so this is a melanoma, case 13. This looks like this is likely ink, and I say that because it's just on the edge. And if we go in, we can see, yeah, it's yellow ink, even though it kind of looked a little similar to maybe one of those ochronosis cases that we saw earlier. And otherwise, it doesn't really look like much. I can see some things here. So I think I want to take a look at this piece, but we'll also look at that piece as well. And this is a much more subtle example of melanocytes having this pagetoid spread, right? This superficial extension of melanocytes through all layers of the epidermis. This looks actually a little better because we can see there's some nesting, and then they're coming up through the superficial layers. Some pigmentation, but most of the pigmentation is within the basal keratinocytes. So remember, this is a melanocyte with the cleft and all that. These are pigmented keratinocytes, so don't be confused by those. Okay, let's take a look at the other piece. But with the superficial spread, like this vertical spread of the melanocytes, see how big some of these are getting? Oh, okay, this is getting scary. There's another one. Oh, okay, this is perfect. So we have these big melanocytes within the basal layers, and then we actually see them right at the superficial layer within the granular layer, or the stratum granulosum. So this is melanoma in situ, for sure, because remember, we should not have our melanocytes within the superficial layers of the epidermis, as we've already said, and we just start seeing more and more of it. And this kind of almost has like a lentigo pattern where it has like this lateral spread, but it's really just like a speckling. So I'd probably still just leave this as melanoma in situ, not otherwise specified. It doesn't look like it's involving the margins. It's getting close, but let's see the other side. Yeah, it's close, but it's not there. So again, you always want to comment on the margins as well, so the clinicians know what to do next. Okay, but this is melanoma in situ. Case 14, and the first thing that catches my eye, besides all this blue, is that this is likely ulcerated. This doesn't look like skin at all, and I think we have maybe a little bit of epidermis over here, and this is detached. This obviously is lesional, but it's floating over here, so I'm not really sure what to make of it. But if we look at this stuff, we can see that, yes, this is fibrin and serum. So this is ulcerated, which we know for melanomas, right? You know where I'm going with this. This is actually a bad feature. And yeah, so we do have a little bit of epidermis, and it looks like it's actually coming around here too. So that's, maybe it's just funny orientation of some of this, but this definitely looks ulcerated. There's some serum crusting at least. All right, we have these nodular nests of somewhat pleomorphic melanocytes. We have some very bizarre mitotic figures, right? Like this one looks like maybe like a smiley face with a cycloptic eye, and this one almost looks like a butterfly or vertebral body. And then we also have normal looking mitotic figures, like that looks normal, this looks normal, this looks normal, but it's a lot of mitotic activity. We do have relatively prominent nucleoli. These ones even look that cherry red, that dark cherry red that we associate with melanoma. Here's another macronucleoli, and it's in this nodular pattern. So we definitely have melanoma, and it is nodular. So we would just call this malignant melanoma nodular type. And right there, you can see it's on ink, so we'd have to mention that too. And you would have to mention that it's ulcerated, okay? We would mention the size, that's ulcerated. There is quite a bit of mitotic activity, so maybe it wouldn't hurt to do like a Ki-67, since that's also one of the prognostic factors that they can look at to determine what's going on. But I think the fact that this is already has serum crusting and is irritated, I feel like this is already saying that this is going to be a poor actor. Case 15. So it looks like all three pieces maybe have something. So let's just start at the, that one looks easier. So let's maybe start down here where it's like, what's going on? Okay. So again, we have serum crusting here. Maybe this is ulcerated too. Oh, this is interesting. Okay, so this is a fun case, and I remember why I put this one in here. So what we have here, let's find a good area. Yes, this stuff. So what we have here is we have dysplastic squamous epithelium that is extending downwards, and in Derm path, we don't like seeing these kinds of things. Your skin should grow up, not down. So what this actually is, or at least one component of this, which makes it so much fun, is this actually has a component of squamous cell carcinoma. Okay. And then again, we have a lot of melanophages. Some of these actually might be pigmented melanocytes, but these big plump ones, those are melanophages. I think the other pieces were maybe a little better for the other features. But okay, so we have squamous cell carcinoma, invasive squamous cell carcinoma. I think those are all melanocytes, but let's see what the other pieces look like. That looks like a giant cell, maybe. This looks similar to the previous piece, which is okay, because this is actually showing us what we need to see too. So these cells, they're a little more epithelioid, which I think makes them a little harder to distinguish. But remember, your melanocytes can be epithelioid, they can be spindled, melanoma can look like everything, right? That's something that we like to beat on all the time when we're looking at differentials. But we still see the same features where we still have like these relatively prominent nucleoli. Look at that one, that's a macronucleoli. There's another one, and they are slightly red. There is this somewhat clearing of the chromatin, which again we see all the time in our melanocytes. And there aren't really well-defined cell borders. Okay, so well-defined cell borders would clue us in more towards our squamous epithelium. Okay, like if we go over here, we can still make out that there's definite cell borders. You can see the spinous processes between the keratinocytes. Okay, so we have this nodular melanoma, we have invasive squamous, and just for funsies, let's see what's over here. Okay, so it looks like we have, again, maybe some pigment incontinence. These look more like macrophages or melanophages because they're filled with melanin pigment. We have some non-specific superficial dermal lymphocytic inflammation that's mostly perivascular. Okay, so that piece actually wasn't too interesting. So what we have here is what's known as a collision tumor. So we have two different types of tumors that are occurring in the same place. So we have an invasive squamous cell and this nodular malignant melanoma. Very cool case. Obviously you don't see these all the time, but this is a collision tumor. Case 16. So what catches our eye is all this intense pigmentation. We have a lot of cellular, okay, as I just jump right in, our epidermis here, and then this intense pigmentation. And these cells actually look a little more elliptical or epithelioid than spindled. We have variation in sizes and shape, and just so many melanophages. So I'm already getting the sense, yeah, that is somewhat scary looking. Some mitotic activity, but some macronucleoli. But this intense pigmentation. So this really gives us, like, at somewhat low power, gives us a sense of like a blue nevus where we have these extremely pigmented lesions with these areas of melanocytes, but the melanocytes should be more spindled. They should have those dendritic processes, and this almost, like, they're large, they're plump, they have these macronucleoli. I'm not necessarily really appreciating a lot of like mitotic activity, but this is, I think, worrisome. And okay, so we're now at like the deep aspect of the dermal portion. Remember, our epidermis is over here, and I'm not getting a sense that this is really maturing. It kind of just looks like the same stuff all the way through. Maybe these, those are like lymphatics. They're very plump, they're irregular. These are scary looking cells, but it has this background semblance of blue nevus. So for this, it likely falls into a malignant blue nevus, and it is really cellular, so you'd probably want to mention that too. Very interesting lesion, very scary too. All right, and for our last case, case 17, so what we see is that there's definitely a dermal component going on here. And it mostly looks lymphocytic. Okay. And then we have these vague nests of really atypical looking cells. These look dyskeratotic, but this looks like a camino body. Wow, look at that. Okay, and this is most likely a giant cell, which you can see with these lesions. And hopefully by saying camino body, somebody already knows what I'm thinking. We have two pieces, so let's go to the other piece, wherever it is. Oops. And we see kind of the same thing, where we have these very large epithelial or almost organoid type cells. Loss of maturity, right? There's no real sense of maturation of these cells as we head towards the dermis. Maybe some, maybe not. I thought maybe we had some mitotic activity, but and we have these nests that extend all the way up to superficial dermis. These widely pleomorphic cells. See if we can find anything else. But okay. So all this stuff together, this looks like an atypical spitzoid nevus. And again, we learned in lecture that to call something spitzoid means to call it atypical. And this is definitely atypical, but without those cellular changes and the loss of maturity, we would just say this is spitz nevus. So this is an atypical spitz nevus or atypical nevus. And this is your last case. So our next slide should be all our answers. So if you found this video helpful, please hit like. If you aren't subscribed to us, please hit subscribe. If you have any questions, comments, items you'd like to see in future lectures, or things that you wish we would go over more in our challenge cases, or things we'd go over less, please let us know in the comments or on Twitter. So we have both Twitter handles below here. And we hope to see you next week with another slide review.